dialogue, which has been organized by SAARC Psychiatric Federation, the IAGMH, and the AFPA, the Asian Federation of Psychiatric Association. So it is, a very important dialogue which we are going to have today, and we have very, very distinguished personalities who are going to teach us, and we are going to interact today. We have our invited speaker, Dr. Carlos Mendonca de Lima. So we are honored to have you, sir, as one of the speakers. And and also we have a panel discussion after that, which is going to deal with dementia in the SARC training and services. And after that, we have, very, very distinguished chairs who are also very important, and they're going to give the input. So without further delay, Debanjan, can we start, and can all the speakers, all the participants, please mute yourself except the speakers, please? Because, we don't want any background kind of noise or sound while the speakers are presenting. So shall we start the program now? Yes, so I've got the nod from Dr. Prasad Rao. So welcome you all, and we start the program with the president of SAARC Psychiatric Federation and IAGMH, our Dr. Gautam Saha. Please, sir, if you give the welcome address first. Thank you. Can you please unmute yourself, Dr. Saha?
Yeah. Thank you. Thank you, Dr. Sharmista. It is really great privilege for me to deliver the introductory talk. In fact, the address, welcome address to all of you. It is a proud moment that we are going to organize today this psychiatric dialogue on geriatric psychiatry. At the initial track, we are proud to say that we have the invited speaker, Dr. Carlos Mendonca de Lima, who is the chair and section of the oldest psychiatry, World Psychiatric Section. We'll talk on the right-based and person-centered psychogeriatric care in the low middle income countries, nations. What are the challenges and future direction? After that, we have a panel discussion, which includes Dr. Sandip Grover from India, Dr. Nidhesh Sapkota from Nepal, Dr. Wazizul Alam Chowdhury from Bangladesh, and Dr. Harischandra from Sri Lanka. And this full session is moderated by Dr. Debanjan Banerjee and will be chaired by Dr. Alka Subramaniam and Navraj Koirala from Nepal. And also, vote of thanks will be given by Dr. Abdul Majid if he is available. Majid Bhai is a very active member of Indian Psychiatric Society, all of us we know. And I'm really grateful Dr. Debanjan Banerjee, who is a very active member of Indian Psychiatric Society. Not only that, in the geriatric field of geriatric psychiatry, he is a really very young star, maybe the young, but his activities, his professional articles, and also in the field of geriatric psychiatry, he has done lots of work. And today's program, I'm really grateful to Debanjan for organizing and taking a great initiative. And always we have Dr. Rajeshri, who helped us for any program of our geriatric from SAARC Psychiatric Federation. And today we have MOC as Dr. Sharmista Chakraborty, always very cheerful and very active, and one of the most academician of our Bengal and Indian psychiatry, always helpful to us. And I am sure that today's program, what we are going to organize, it will be a great show. And I hope that after some times, more people will join, and it will be a great program. And definitely Dr. Carlos and the others panelists will definitely enlighten us regarding the geriatric psychiatry, regarding they will justice their topic. And I don't want to take much time. And over to Dr. Sharmishta Chakraborty, please.
Thank you so much, Dr. Saha, for your encouragement as always being the leader of SAARC Psychiatric Federation and IAGMH. We are very, unfortunately, Dr. Afzal Javed could not be with us, but of course we have his blessings. Could I request Dr. G. Prasad Rao, the president of AFPA, to give the welcome address, please? Dr. Prasad Rao.
Thank you so much, Sharmishta. And my younger brother Gautam and myself are never separable, never separated and never inseparable. We all work together. And today is a really a historic day when almost 3 associations are organizing a beautiful webinar, especially focused on our dementia patients. It's a great honor to be part of it. And I know the youngsters who are now going to talk, and not so young people like us, listening to most of them is a wonderful experience, which I think we cherish for our rest of the life. Particularly, I would like to recall Professor Muhammad Wazizul Alam and our Nepal friends. I think our Nepal president has come there right now, and our Sri Lanka friends, and I'm sure all these SAARC countries are being represented by all the other people. So it is a great, great day for us, where 2 hours of undiluted academic festival is going to happen. I bring greetings from the Asia Federation of Psychiatric Association, and I wish that we continue this academic discourse very regularly over the next few years. Thank you very much, Gautam Saha. Thank you, Debanjan. Thank you, Sharmishta. Thank you, Abdul Majid, who is always with me, always with me. I'm here waiting for you in Jaipur. So all the best for you, and all the best future for SAARC, AFPA, and Indian Association of Geriatric Mental Health. Thank you very much.
Thank you so much, Dr. G. Prasad Rao, you have done, huge academic work and has been always encouraging us to do such programs. Thank you so much. So after that, I would request Dr. Imtiaz Dogar, the General Secretary of SAARC Psychiatric Federation. I'm not sure if Dr. Dogar is here. Is he here, please, sir? If so, I can't see him, so I'm not sure whether he is here. Dr. Dogar, are you here?
Checking. I'm calling him. I think you can go ahead. Okay. Dr. Sharmishta, please.
Yes,
proceed.
yes, sir. I think, if Dr. Dogar kind of joins in, we can, get the address once he joins us. So let's start the invited talk for which we are here today. And we have our guest speaker, Dr. Carlos de Mendonca Lima, who is the chair of WPA section of Old Age Psychiatry, very actively working in WPA and with the International Psychogeriatric Association for Human Rights of Older People, Dignity and Rights-Based Psychogeriatric Care. The topic today is rights-based and person-centered psychogeriatric care in the LMIC nations, challenges and future direction. The chairperson, I would like to call upon the chairperson, Dr. Gautam Saha and Dr. G. Prasad Rao to start the program, please, and introduce the speaker as well as the topic. Thank you. And over to Dr. Gautam Saha and Dr. G. Prasad Rao.
Dr. Rao,
Yeah, thank Mr. I think Gautam would introduce Carlos, and then I will talk about the human rights, where then we both will not stand before you and the speakers, all the audience and the speakers. Yes. Gautam Dada.
It will be very nice if our dear brother Dr. Devanjan will introduce sir, then we will start. Devanjan, it will be better because you'll introduce him better. I already have talked regarding his chair and other things. You can elaborate.
Thank you so much, Dr. Saha and Dr. Prasad Rao, Dr. Sharmishta. Thank you for mentoring and guiding this program. It's one of the few dedicated programs on old age psychiatry that we had from these associations, and it's always great to be a part of it. Normally, we usually discuss clinical work, but this time there was a bit of diversion, and we thought of discussing human rights and a person-centered approach. It's always a great pleasure to have Carlos here, very dear colleague. We have worked in several ventures and continue working in separate specific human rights-based ventures. And one thing is he never refuses to be there. The moment I requested him, he was there. He made time. So thank you so much, Carlos. Dr. Carlos D. Mendonca Lima is the chair, as Dr. Sharmishta mentioned, of World Psychiatric Association section of Old Age Psychiatry, abbreviated as WPA-SOAP. And he is extremely active and has done a lot of work in what he's going to speak today to us about, specifically the latest initiatives when there have been several documents which have been sent to the open-ended working group of the United Nations Office of the Human Rights Commission. And it will be great to listen from him about how, he being in a very important leadership post of WPA Old Age Psychiatry section, how he envisages what can be done in the lower and middle income nations, particularly for the betterment of mental health in older people, and also taking a very person-centered, person-centric approach in that regard. So thank you, Carlos, and over to you. I think
Devanjan, it is great. Thank you. Thank you, Devanjan. It's you introduced Dr. Carlos, and what I'm telling it, the topic is right person-centered psychogeriatric care in the low middle income countries. We are actually facing day to day in this problem, and what are the challenges. So it will be definitely, we are eagerly waiting to listen her. I don't want to stand between sir and science. Over to Dr. Prasad Rao, and he will speak, and after that, sir will tell us, Dr. Carlos. Dr. Prasad Rao, please.
My dear Carlos, we are very much thankful for you, for your time and being with us. I know we are literally the thousands kilometers away from you, but I know you took time to talk to us. I have heard you many a times in WPA2 congresses, where you are quite clear, lucid, and also very attractive speaker. And you are touching the topic of not of the, let's say, better West country. You're touching on the lower middle income countries of this continent, and we are part of that. Thank you very much, Carlos. I appreciate your time, and I'm eagerly waiting to learn and get enriched by your knowledge of how to go about in the subject which you are going to talk right now. Thank you very much.
I would like, first of all, thank you. Everybody has invited me to this activity, and ask to those are preparing the presentation, because I'm unable to share my screen. I need to have access to my presentation. It's I have
Dr.
a little.
Carlos, we made the host, please.
No, I don't know how to.
Guys, Make him co-host, please.
Yeah.
Yes, sir. Doing.
Okay.
I have access to my presentation.
Yes, sir. Already I've made him, sir.
Dr. Carlos, you can
I have
Yeah.
made him your host, sir. You can carry on, sir.
I'm not getting it.
Yes, sir. You are host now. You can share your screen, sir. Hello.
Hello?
You can share your screen, sir. You are now
Angelique.
host.
Okay, now, okay. It's fine. And so, you are seeing it?
Yes, yes.
Yes, okay. So,
Yes, yes.
I thank you very much for inviting me. I'm very honored to be able to address to the people from other side of the world. I'm speaking from Switzerland, but I came at the origin from Brazil. So I'm very comfortable to talk about a low and middle income country. But as you see, what we are talking today, human rights, is a problem of everybody, not only a problem in low and middle income countries. But anyway, thank you with all my heart for being with so distinguished colleagues. Listen to me. I don't think I have something to teach you, but to share with you my experience in WPA. So, as you know, the world population is aging quite fast, but in different speeds. At the black line here, you have the average of the global aging population, but you can see here that over the mean, there are the lines corresponding in majority of the low and middle income countries. I mean that the speed of aging is occurring more in South America, Asia, Africa than Europe and North America, because these regions, they have got already the maximum of the power of the aging growth. But in the next years, so the huge tsunami of aging will come from the low and middle income countries, which represents an enormous challenge for these vulnerable economies and civilizations. As you can see here, the number of countries with a long-term care policy, plan, strategy, or framework, standalone or integrated with an aging and health plan, is in the majority in Europe. And the other regions, Africa, Americas, South Asia, West Pacific regions, the majority of countries don't have in the policy or mental health policy or health policy integrated still the aging process, which represents a missing opportunity and a lack of possibility to better organize care, prevention, promotion of health in these regions. And there is an equal aging across of life course if you invest or you don't invest in people, in aged people. Since the early childhood, when, for example, we invest in the birth, adequate nutrition, access to health care, you have a better conditions to improve the quality of these babies, to reach at the school age high quality of education. If you put conditions of working and in protection, social protection during adult life, you will have old people in better health and sufficient patient income access to ensure an end of life with dignity. Without these investments, we risk to not contribute to the development of the children. They will not have access to good quality of learning in school. their conditions to have an income during the adult life will be very poor, limited, and at the old age we will have assisted old person with a health poor and insufficient personal income and no assets. In our book, I have demonstrated that the factors that influence older adults' mental and emotional well-being include individual characteristics, of course, but much more that are the socioeconomic circumstance people has aged and the broader environment in which they live. So mental health problems in adults globally, and this is also dramatic, underestimated and underdetected by healthcare professionals, not only in low and middle income countries, but also in countries such as Switzerland and Europe in general. We have this problem too, but with different level, of course. At the WHO 2022, it was clearly pointed that investing in mental health is the sport of human rights violation. And the human rights violation in mental health care is becoming clearly the most challenging field in all countries in the world to protect people with conditions. So people with mental health conditions are frequently excluded from the community life and denied basic rights. They are subject to human rights abuse by some of health services responsible in their care too. So many times we, in our clinical activity, may violate the human rights of our patients, and we have to think of that and prepare to make change in our way we are caring people. The recent WHO guidance on community mental health service has pointed that the person-centered, human rights-based and recovery-oriented care is the way of we have to plan the care for the future. It's a strategy of mental health service to provide quality care and support according to the increased awareness. But globally, service face substantial resource reductions, operate without outlay the legal and regulatory frameworks, so lack of mental health policies, and over-reliance on the biomedical model with the pregnant focus on diagnosis, medication, and symptom reduction, when we can make a lot of things to protect and care people, just acting on what I mean, the social determinants of mental health care in old age. And this is what the community mental health care, community mental health service can do, not only make the proper diagnosing and treatment, but also improve locally and regionally and nationally the conditions the people are all aging. For example, the social determinants consist in improving the housing conditions. Adequate housing means accessibility, affordability, ability, and so forth. We have to plan good social security for old people and also during the aging process of life. Easy access to responsive security systems is a priority. Give good education not only for children, but all long life, reduce the literacy of old adults, and we can also demystify ageism and promote human rights, affirming positive aging globally. Good conditions of work not only for adults, but also for old people. Combat exclusion to the right to work of old people. Recognize their skills, include them in job rehabilitation programs, and so forth. And finally, improve the conditions of food and access to health. So acting on the social determinants, we can promote a very good mental health for old people and for during the aging process in all countries in the world. So the full range of social determinants that impact people's mental health are overlooked, all of which had a progress toward a full realization of human rights-based approach. Many people with health conditions and psychosocial disability are subject to violations of their human rights, including in care service. So this guide, WHO Guidance on Community Mental Health Service, has points, it describes in 7 levels of care how we can do and promote this center-based approach for old people. In mental health crisis service and hospitals, community mental health centers, peer support mental health service, community outreach mental health service, supported living for mental health, and comprehensive mental health service networks, how to build them. Since 1997, we have organized in Lausanne the Organization of Care in Psychiatry of the Elderly, a technical census statement by WHO and WPA. And we have shown that and demonstrated that the individual patient, when they need support, he looks for family and carers and in the community. So to surround people with the professional care is a good way to support them. This is repeated by, for example, HelpAge in this recent report, achieving universal health coverage for all in aging world. They mention almost the same, to surround people who in need with the specific care they need, including health and well-being promotion, disease and disability prevention, early diagnosis, specialist service, rehabilitation, long-term care, and support, and palliative and end-of-life care. Well, as I have mentioned several times today, human rights is a clue to guide us to develop service and the good care in the future, not only for old people, but for all. But concerning what is have been done at the United Nations level, we have to consider the first World Assembly on Aging, which was in Vienna in 1982. This was the first time the United Nations had taken care of the problem of aging seriously and has promoted 62 recommendations for acting, addressing research, data collection analysis, training and education, as well the health and nutrition, protection of elderly consumers, housing, family, social welfare, income security, and education. So in 1982, the United Nations has pointed the direction to develop the future of the application of good human rights in the aging process. 20 years later, after the Second World Assembly on Aging, it was produced the Madrid International Plan on Action and Aging. And at this time, United Nations decided to go forward, proposing to establish an open-ended working group to discuss the opportunity to create a convention to the Universal Declaration of Human Rights. Because in fact, besides the Universal Declaration is theoretically universal, this declaration has shown limits in several levels to protect specific groups, such sorry for that, such yes, here, such women, for example, and they have created a convention in the 60s, 70s to protect the human rights of women. After that, it was the children. And now, by 10 years ago, it was the CPRD, the Convention to Support People with Disabilities. So these 3 conventions have shown a powerful instrument to implement what is said for the specific groups, vulnerable groups, what is said in the Universal Convention, Declaration of Human Rights. And we need one now for old people. And the Madrid International Plan of Action has created the conditions for that, or proposing the open-ended working group. So, until today, a human rights framework specifically for old people is still missing. And this is necessary because the special vulnerability of old people by virtue of the social ageism, stigmatization, discrimination, exclusion, as well by the disability dependency which mental illness in old age may confer. That's why WPA, Section of Old Age Psychiatry, is working together with the National Psychogeriatric Association to develop strategies to implement human rights in the mental health care of old people, and also to push to approval the Convention on Human Rights for Old People. So as we have common goals, we are working together since the 10th December 2020, when at the Human Rights Day, we have proposed by WPA and IPA a webinar series, at the webinar series, a webinar discussing the problem of human rights. It included Professor Mira Dassen, Franz Verre, Lapid, myself, invited Kiran Habiru as moderator, and the speakers was Professor Norman Sartorius, Israel Doron, and myself. After that, we have produced an IPA and WPA SOAP joint statement on the rights of old people with mental health conditions, and this was published at the International Psychogeriatric in 2021. This document was sent to the 11th session of the United Nations Open-Ended Working Group, which every April since 2010 is meeting in New York, United Nations. So the Open Group, the 11th session has received our document and has included in the file report. Now, WPA this year, next September, will approve this document as a full WPA statement after being approved by 140 countries around the world that are members of WPA. The next document that we have produced together consider the old woman's human rights and mental health. This document was the answer to the call for input in 2021 on the thematic report on human rights of old women by the Office of the High Commissioner of Human Rights, the United Nations. Another document produced by us was the ageism and the state of old people with mental health conditions during the pandemic and beyond. So the COVID, it was an opportunity to discuss how the human rights of old people are violated around the world, and most particularly in the low-income countries. So this was the answer to the call for input of the thematic report on ageism and discrimination. These three documents I have mentioned were included at the final documents addressed to the United Nations General Assembly. For example, the human rights of people, the old persons and the right to adequate housing, and the report of independent expert on joint human rights of Pedro Claudia Meller. So these three documents read at the United Nations General Assembly only by July 21 and 22, include and make reference of our papers. Another action that was very interesting was the publication at the American Journal of Psychiatry of a special issue on November 2021, a special issue concerning old age psychiatry and human rights, proposed by Kiran Habiru, which was the editor of this document. The two editorials are here, but have included 12 articles of several fields and domains where the human rights in old age can be considered. We have discussed after international consensus statement on the benefits of reframing aging and mental health conditions in a culturally inclusive, respectful manner, published by the International Psychogeriatrics. This article mentions how, when we talk about old ages, we can still already mentioning old age and then treating them in the way we talk, we can make discrimination and stigmatization. We have proposed to WHO, who is preparing a guidance on mental health human rights legislation, which will be published very soon. We have made our input what was considered by the WHO. We have published an abuse and violence against old persons by Carmen Pesa and others. This is another input to the Office of High Commissaire. We have published also old persons in climate change induced hazard, and this will be published very soon by the International Psychogeriatrics. We have published a position statement on the privation of liberty of old persons with mental health conditions and the right to the education through of life course, which was approved by the International Psychiatrics, which is, have already published the online version. Finally, the human rights conventions and declarations are important to protect the human rights and influence the way we are treating old people in the activity. So the Convention to Elimination of All Forms of Discrimination Against Women was approved in 1979. Rights for Children adopted in 1989. The Convention on Rights of Persons with Disability in 26. And now we are all together waiting for the possibility to approve the Convention of Rights of Older Persons. The 12th Open-Ended Working Group has met this April 22 and has already an appointment for April 23, 24. Each one of you that are listening to me are responsible to make pressure to your own government to be signatory of the proposal of a convention on human rights for old people. So I'm in contact, direct contact with the Swiss government to push the Swiss to approve and be a signature of the convention, the proposed convention. We need at least 3/4 of countries of the United Nations approving this convention to make this a reality. This year, 2023, we are celebrating the 75 years of the United Nations Declaration of Human Rights. And we are trying to plan, IPA and WPA, a series of activities for the next December 10th to celebrate this and give our input that human rights in old age is very important to us, and that not only for young people, as is mentioned in the document, inviting us to join our efforts to the United Nations. So in conclusion, mental health conditions in old age kill, not only in low and middle income countries, but everywhere. But the violations of older adults, human kills too. And we have to make a lot of attention of both to treat our patients with dignity. So I thank you very much. I'm ready to answer to your questions. And I invite you all to join our section. You go to the WPA website, we'll find the section of old age psychiatry there, and join our section, click and make your candidature. I will come very well, all of you. Thank you very much, and I hope to see you in Vienna next September, where we'll have the World Congress of Psychiatry, and we will discuss several of this theme together. Thank you very much.
Thank you very much, Carlos. I have a few questions. I know on paper it's a very document, but my question is, from your survey, in how many low-income countries do we have a psychiatrist population trying to meet the demand of the population suffering from geriatric problems?
So the question is, sorry?
No. In low-income countries, the problem is not having adequate geriatric psychiatrists.
Yeah.
Or you can say psychiatrists who are there.
So we have made a survey.
Do you have any data?
I don't have data. We have made a survey and will be published at the World Psychiatry about how old age psychiatry is being taught around the world in the countries member of WPA. And at this point, we will be able to say to you which countries in the world are ready to make the change to introduce human rights in the treatment of people, okay?
And see, our population in India, for example, we are about 9% is by definition geriatric, 65 plus. So, and the age in which to call older age is changing. The definition to define the old age. So, what is your take on that?
Anyway, what WHO says is that in low and middle income countries, since 60 years old, we are already old in these countries. While in the high income countries, 65 is the moment of life where we became theoretically old. But this is very is very arbitrary, and what is the most important is not when we become age, but how we are aging through our long life process, you see? So to reach old age and good health, we have to prevent disease since the birth. So it's a long effort to age with health. And we are living now, and this decade, the project WHO is aging with health. It's the leitmotif of this decade. So let's have this opportunity to discuss all this inside of this project of WHO.
One last question. I think we need to develop through IPA and WPA, Geriatric Psychiatry section, low-cost models of psychiatry delivery. For example, telepsychiatry has come. What is your comment on that?
But of course, we have to rethink how to treat people in those countries with less cost. As I has pointed, the clue is to focus in primary care first. I think that primary care has a high responsibility, but the people who was working in primary care is not ready still to identify, make the early detection, and how to manage old age psychiatry, mental health issues. That's why I have published the book on primary care, mental health in old age. I think and I believe that the all efforts is to give primary care empowerment to do this job with old people.
Thank you. Gautam, do you have any?
Sir. It was an excellent presentation. We are really grateful to you to participate and being an invited speaker in our program on behalf of SAARC Psychiatric Federation, and definitely for Dada on behalf of AFPA, Asian Federation of Psychiatric Association, both the organization. We are really grateful to you. And it will be a great honor for us. We have delivered a very insightful lecture and we learned a lot. And I think over to Dr. Sharmista Chakraborty, please.
Thank you so much, Dr. Carlos, for that very, very enlightening talk. And with that base, we swiftly go on to the next session, which is a panel discussion dealing with dementia in the SAARC countries, training and services, which is a very, very important topic, keeping the invited talk as a background. The panelists here, we have very distinguished panelists and moderator. The panelists here is Dr. Sandip Grover from India, Dr. Nidhesh Sapkota from Nepal, Dr. Wazizul Alam Chowdhury from Bangladesh, Dr. Harischandra Gambhira from Sri Lanka. I would request the moderator, Dr. Debanjan Banerjee, to take over, and also request the chairs, Dr. Alka Subramaniam. I don't know if Dr. Alka Subramaniam has actually come out of her plane, Dr. Nabaraj Koirala from Nepal. So over to Dr. Debanjan Banerjee, the moderator of the session. Thank you.
Dr. Alka is joining shortly. Just in a
Okay,
minute.
excellent, excellent. So we'll have her shortly, and over to Dr. Debanjan Banerjee to start the session, please.
Yeah, thank you, Dr. Sharmishta, for the kind introduction. And I think we have an important panel discussion here, which kind of follows through what Dr. Carlos had mentioned in his lecture. I'm not sure if Dr. Imtiaz, Dr. Nabaraj is present. Is he there?
Yes, let's go various changes and zooms. Except change.
I think I'm not able to see him. So
Dr. Alka has joined.
No, sir, he is not present, sir.
okay.
Debanjan, go ahead. I'm calling him. No issue.
Yeah. Maybe we'll just wait for a minute since we don't have both the chairs.
Debanjan, I'm here, but I'm traveling.
Oh, okay. Okay, ma'am. Hi, no problem.
problem.
So Dr. Alka is here, and we'll wait for the other chair to join. So we have 4 distinguished panelists with us. We have Dr. Sandip Grover. He's a professor and from the Department of Psychiatry, PGI Chandigarh, and the editor of SAARC Psychiatric Federation, the Journal of SAARC Psychiatric Federation. Is also the editor-in-chief of the the Journal of Geriatric Mental Health, which is the official publication of the Indian Association of Geriatric Mental Health, and is an affluent academician with several publications in the field. Welcome, sir. It's great to have you here.
Thank you, Debanjan. It's my pleasure to be here. And I look forward to the panel discussion. Thank you.
Thank you. Dr. Nidhesh Sapkota, he's the senior geriatric psychiatrist from Nepal, and he works in the field of old age psychiatry, one of the few old age psychiatrists in the country, and he has kindly agreed to be one of our panelists here today. Welcome, Dr. Nidhesh.
Thank you so much. It's my really pleasure to be here. Thank you so much.
Thank you. We have our dear Dr. Wazizul Alam Chowdhury. He's the president, the Bangladesh Association of Psychiatrists, and has been one of the office bearers of the SAARC Psychiatric Federation as well. It's always been very supportive for all the SAARC programs. And thank you, Dr. Wazizul, for being with us today as one of the panelists. Dr. Wazizul, are you there?
Yeah, thank you very much.
Yeah,
Thank you very much. Do you hear me?
Yes, yes,
yeah,
I can.
Thank you.
Yeah, Debanjan, he is the treasurer of SAARC Psychiatric Federation as well as past president of Bangladesh Psychiatric Society, immediate past president.
Yes, thank you for joining us, Dr. Wazizul. I know it's a busy schedule for you, but as always, thank you for being there. We have Dr. Harischandra Gambhira as one of the other panelists, but I guess he's not joined us till now. Is he there?
I think he is not there, sir.
He is not there. He messaged me in the evening. He has some problem and he will try for joining. He told like this, but I don't know. I think some problem is there. Okay, go ahead.
Fine. So, of course, in a panel discussion, even though, we look forward to hearing from the panelists, and it's more of an informal discussion, starting off from where Dr. Carlos has left us. But it's also important that the audience chips in with their comments, queries, and insights, so that we can incorporate them in the discussion and we can put forward to them to the panelists. Please feel free to either send me a personal message or put it in the group so that everybody can have a look at it, or your queries, or if you want to address anything specific to the panelists here today. And I also will request all of you to mute themselves except the speakers so that we can have a smooth and relevant discussion. Now, when we kind of thought of this program, and of course, we had a discussion with Dr. Gautam and Dr. Carlos. I mentioned that in the very beginning that we spoke about a rights-based perspective, and all the documents that Dr. Carlos mentioned are the conjoint works of associations working in the field of geriatric mental health to bring about a certain degree of change in thought and actions with regards to how psychogeriatric services operate. Now, today's panel is titled Dealing with Dementia in the SAARC region, Training and Services. We have panelists who work in this area, who are leaders in respective regions, and not only in terms of clinical acumen, but also in terms of research and being teachers themselves, which is very important. So we would like to hear from them. Dementia, as all of you can appreciate, is a burning issue that arises as a global public health problem. Today, as of now, the rough estimate runs as 55 million people affected with dementia worldwide, over which 60%, of which 60% live in the lower and the middle income countries. And every year, based on the World Health Organization data, there are nearly 10 million new cases, predominantly Alzheimer's, but today we will not limit our discussion to just a subtype of dementia as a whole. Also, it's important to remember that dementia leads to a lot of economic burdens, not only to the family, but also to the society at large. And it affects both morbidity and mortality. Now, the South Asian population accounts for nearly 1/5 of the global world population. And many of you who recall the 10/66 study, it was phenomenal, just concerning to know that even though nearly 2/3 of world's dementia population reside in the developing nations, less than 10% of research has been dedicated to them. So here we are today to try and start changing the dialogue, both in terms of services and training. I'd like to go to Dr. Sandip Grover first. Sir, you have been working in this field extensively for many years, both as a clinician as well as a researcher. What do you think, when we talk about dementia, a growing number of cases in the South Asian population, being a researcher and a clinical practitioner from India, what do you think are the predominant challenges in dementia management in our country and South Asia as large?
Yeah.
Dr. Grover.
Thank you, Devanjan, for your question. I think we need to first understand in South Asian countries and this whole region, first we have very few number of psychiatrists. So mental health resources or the mental health human resource is limited in these countries. That's number one. And when we talk about the geriatric psychiatry per se, or people who are working in the, who are focusing on the people of old age, is further limited. So from that perspective, we have very few geriatric psychiatrists in these countries. That's number one. And number two, there are very few training resources available in these countries in the form of training during the MD psychiatry training. Also, the exposure to geriatric psychiatry is not much. And post MD training resources are also very much limited. So due to all this, we do not have adequately trained manpower to cater to the needs of patients with dementia. And besides psychiatrists, we do not have other healthcare professionals like courses related to psychiatric nurses or the clinical psychologists also in adequate number, that who can carry out the so-called non-pharmacological interventions for these disorders. And similarly, we do not have resources for training the family members for they being able to take care of the patients with dementia and those elderly with various mental health conditions. So here we stand that these are the problems which we have, but we have to make a beginning. And I think there's a lot of beginning which has happened in last 10 years in India. We have a lot of centers now coming in with providing training to the psychiatrists in the geriatric mental health. And also we have certain training resources which are coming up to train the caregivers. Indian Association of Geriatric Mental Health is taking a lot of initiatives to address these issues. And in fact, this year's theme of the conference is talking about relationship and the caregiving in the patients with geriatric mental health conditions. So that's where we stand now, but I think still a long way to go. Thank you.
Thank you, sir. I think you very aptly mentioned about the need to improvise resources, services, and also about the importance of sensitizing existing mental health professionals on the same. Dr. Nabaraj Kairala is here with us. Welcome, sir. It's a pleasure to have you here. Moving on to Dr. Wazizul, where Dr. Grover mentioned about caregiving, I think it becomes a very important part of dementia care because we have to deal with the mental health and well-being of the caregivers as well. Now, both from your position as a leader in the association, Bangladesh Association of Psychiatry, as well as in your clinical practice, with regards to training in dementia care, particularly at the MBBS level, the MD level, or, those who are fresher who graduate in psychiatry, what has been your experience? Since we are thinking of strengthening the ground level of dementia care stuff, how do you think we can improve their sensitivity and understanding in dementia care? Dr. Wazizul.
So thank you, Dr. Devanjan. Actually, before going to your subject, I would like to congratulate our learned speaker, Dr. Lima. I would like to offer my heartiest thanks to our chairperson, Dr. Gautam Saha, our chief guest who couldn't attend for some definite reason, for Dr. Javed, so Dr. Prasad Rao, and the other panelists, Dr. Mr. also. Actually, it's a very important question indeed. Actually, what our senior citizen demands or deserve from us, or what we should do for them or we should provide for them, it is very simple. That is, some comfort, means food, shelter, treatment, and recreation, work like education and employment, security, and dignity. Possibly, most of the conditions are rather fulfilled by some of the families. The one thing is very important that has been mentioned by Dr. Lima, that is the rights, human rights, or I should say the dignity. We can't provide it. So if we want to provide this simple support to our elderly persons like our grandfather, our mother, or grandmother, or so on, that is we need to build up a structure, a system, and personnel who can morally support them, who will be very sincere, who will be very kind, and who will know how to honor a senior person. For this reason, definitely in response to the global challenges of population aging, it is crucial to improve research, education, and clinical training in old age in order to meet the growing demands placed on psychological and psychogeriatric care services. So I think it should be the important step for us, like organizations, to implement geriatric psychiatry with more emphasis the undergraduate level, postgraduate level, in the in-service training, not only for the doctors, but also for all the health workers, those who are training in the cities or sub-cities or sub-district and even in the field. So it is the basic thing to improve or increase the number of health population with that orientation to help the senior citizens of the country. So thank you very much after this.
Thank you, Dr. Wazizul. It was, really insightful for you to talk about primary care training. I think that's very important
Yes, very much.
dementia care. Since Dr. Grover started by mentioning a resource limitation. Now, resource limitations, of course, is a major factor and it's going to stay. So one of the things that, ideally that comes with resource limitation is also optimizing the. So with this, I will go to Dr. Nidhesh. Detection of dementia, something which is very challenging since, one fine morning, somebody doesn't stand out having memory decline. So detection is always a concern because, we all know that people will not really present to you with memory problems. Family will mostly bring them to you when they start having behavioral issues. So forgetting is often considered or normalized as a part of aging. So with regards to a geriatric psychiatrist yourself, with your years of experience, how much do you think is a problem? This is a problem, the late detection once it's already advanced. And how do you think, at least in South Asian nations, early detection of dementia can be optimal? Dr. Nidhesh.
Thank you, Dr. Banerjee. This topic is very, very favorite to me. Okay, like eyes cannot see what mind does not know. If we do not know that this forgetfulness can be an issue, people tend to think this is an old age issue. Okay, like for example, if you talk to my country or any Southeast Asian countries, any elderly people, if they forget, they tend to think that this is old age issue. Why to consult to a doctor? So this awareness is lacking, and this breeds. And we know that elderly cohort, this population of elderly cohort is exponentially increasing. Like in my country also, if we go back to the last census, national census, and the latest one, which was published in 2021, there was 10.21% of the elderly population that is 60 years and elder. And these are the population who are likely to suffer from memory issue. So now detection goes on. I always try to focus on the detection should start from home itself. If the caretaker, primary caretaker can be son, daughter-in-law, daughter, anyone, if they can pick this issue, and I think in our country and in India or in other countries as well, we have volunteers, female healthcare volunteers. They visit every household. So even they know this lady or this gentleman is forgetting since last time I visited. So if they can pick this, then memory basic screening can be done. So what we have started in Nepal, there is a WHO initiative program. They have integrated care for old age people ICOP manual that has been introduced, and we have 77 districts, and this has been integrated in primary health care service providers. So through this manual, and even we started training, we started providing, like Professor Koirala is here, he is one of the trainer. So what we have started doing is, we have started using that manual, mental health gap action program, that manual. We started giving training to nursing staff, giving training to medical officers, paramedics, everyone who comes to the to cater the mental health, the services in the lower level. So what I believe is, if we do not integrate that mental health care services, geriatric mental health care services, memory screening services in the vertical level from home to the topmost tertiary level, in big medical schools we might miss. We have more than 150, 200 cases in OPD. It's not possible to screen each and everyone. So this screening should be done. So we should be able to screen out all the cases that we feel they may have some memory issue. Okay, so this training should be integrated through some module, like we have started in Nepal by using ICOP module and this mental health gap action, the program module 2.0 version. So I think we need to start, we need to do something. And in tertiary level center, we can use different screening tools or diagnostic tools that can be done. But it should start from the healthcare providers working in the primary care center level at their doorstep, that I believe.
Thank you so much, Dr. Nidhesh. This was wonderful to know about this model because, there was once a discussion in IPA if the South Asian nations as a homogeneous group can come together and develop an integrated model of care where it can be more of a top-down approach and, there can be different levels of training utilizing the primary care, the base grassroots health workers that we have in detecting. And once that kind of comes up, then we actually have more and more people in our, clinical attention. And we can probably slow down the progress because now we know that there are several lifestyle changes that can be adjusted to in individuals with early onset cognitive decline. We have some comments and some questions with us, but before that, since the respected chairs were not there when we started, may I request a quick comment from Dr. Alka and Dr. Nabaraj Koirala to add to the ongoing discussion. Dr. Alka, are you there, please?
Yes, Devanjan, I'm there, but I'm sorry, I'm in a low network zone. I can't put on my video. So good evening, everybody.
No problem, ma'am. Then no problem.
And it's really wonderful that we're having this this combined discussion, and thanks to our President, Dr. Gautam Saha, for getting everyone on board with SAARC, IAGMH, as well as AFPA, and all the dignitaries who have spoken before. This panel, like everyone has said, is so important, but what is beautiful is all the panelists from the various countries are actually bringing out the ground realities. You see, when we are talking about the LMIC countries, I think we've gone a little beyond that, but we are not completely developed yet. We are really low on resources and funding, and how to manage to provide quality healthcare despite that is what India, Nepal, and Bangladesh are bringing out. We are missing our Dr. Harischandra from Sri Lanka because Sri Lanka has done some pioneering work in training at a very basic level. And we would have loved to hear that. But I think you can go ahead with the panel and let's hear further what they have to say.
Thank you, ma'am. Thank you for joining us. I know you're traveling, but, thanks as always for your guidance and encouragement. Dr. Nabaraj Koirala is here, and as Dr. Nidhesh was mentioning, that he has been one of the guiding force behind this module implementation and trainer in Nepal. So, Dr. Koirala, your quick insights, please, before we proceed with the panelists again. Dr. Nabaraj, are you able to hear me?
Oh, yeah. I saw him there. Dr. Koirala is there.
Yes, sir. Dr. Koirala is there.
Unmute, please. Dr. Koirala. Manisha?
I think I am not. Yeah, I can see him. Dr. Koirala, are you able to hear me?
Sir, I have already asked him to unmute.
Okay, no problem. We'll circle back to him. Maybe he's facing some technical issues. So we do have a comment here. Dr. Professor Mahadev Chandra Mondal mentions that basic training is essential of primary caregivers. Yes, thank you, sir. I think that's been highlighted by your panelists as well. In regards to one of the questions that we had, I'll come to Dr. Grover. In terms of the freshers, especially individuals who have recently completed their MD training, who probably didn't get a chance to go through the diploma or further studies in geriatric psychiatry, what would be your suggestions, or how important do you feel is to probably sensitize both MBBS final year students as well as, post MBBS? I'll not mention the post MBBS doctors here because that's a part of the primary care. But in terms of training and curriculum, how important do you think is to incorporate a separate, dedicated training in dementia care, both in MBBS as well as in MD psychiatry? And would you recommend or suggest anything for the panelists or the audience across the South Asian countries?
Yeah, thank you, Devanjan. I think when we talk about training of MBBS students and MD psychiatry students, what we need to understand, I'll not limit myself to training to only dementia care, but elderly care of all mental health conditions. And I am a very strong advocate of doing psychiatry training in a consultation license psychiatry setup. So because all the elderly patients, whether they have a diagnosed mental health condition or not, they do get admitted in medical surgical wards. That is the place where you have an access to these people, and they may not be having diagnosable illness, but these are the people who are at a risk of developing dementia, who are at a risk of developing geriatric mental health conditions. So sensitizing MBBS students and doing psychiatry training of MBBS students in the consultation license psychiatry setup, so that they can be made aware how mental health conditions interact with physical health condition, how dementia can be screened, how cognition requires screening in patients of diabetes, hypertension, and so on. So that is the best way to train the so-called MBBS students, sensitizing them about the mental health conditions in geriatric age group. This will also help us in training specialists in other branches like physicians, internal medicine residents, surgery residents in understanding the mental health issues for geriatric people. Because this is where what happens is that when we are just doing all this training in a psychiatric setup, we are not allowing, we are limiting ourselves to a group of people, those who have diagnosed psychiatric conditions. Whereas we are losing out on a whole chunk of patients where we actually can do the inputs through the physicians, through the MBBS students, and look for prevention. So that's where I would focus on when it comes to MBBS students. Similarly, for MD students also, when we're talking about their training, there should be, all departments should start now developing geriatric clinics or geriatric subspecialty in the institute, and try to have a training period of about 2 months in geriatric psychiatry, which should be dedicated training. And there should be institutional exchange program. If somebody doesn't have a geriatric program at their institute, they could be sent to the other institute with good geriatric program. And similarly, people who have completed MBBS or MD wants to have a geriatric training, they can have short-term observership, short-term fellowships, by which they can improve their geriatric skills. So I'm not just talking about taking care of dementia patient, but taking care of all the mental health conditions in this age group, which is a very vulnerable age group, and we all need to get used to understanding their issues. Thank you.
Another point, Dr. Devanjan, I add with Dr. Sandip, that especially for the Indian psychiatrists, those past MD or even in the MBBS, to become a member of Indian Association of Geriatric Mental Health, because we are regularly doing program on behalf of this, the case presentation, and from the different institute already we have done in this year, from one from the Nimans and another one from the Asha Hospital, Hyderabad. And it will be really great. And it is not only for learning for yourself, but also we can learn from your experience. That is a sharing of knowledges, actually. I request everyone to be a member of Indian Association of Geriatric Mental Health. Dr. Devanjan.
Thank you, Dada. Thank you, Dada, for making that point.
Thank you, Dr. Grover and Dr. Saha. I think it's a very important thing that Dr. Grover mentioned, involving, you know, I remember when my training in DM, I always heard this from my professors, that you cannot practice geriatric psychiatry sitting in the AC room of your chamber. So it is important to integrate them with various specialties, multidisciplinary care, comprehensive assessment. We always not only need a consultation license setup, but it's always, and especially since we are talking about dementia care, it's a collaborative, concerted effort between a psychiatrist, neurologist, a psychologist, a neuropsychologist, a cognitive rehabilitation specialist, occupational therapist, speech therapist, physiotherapist, and so on. So, each have their own role, and it's important to integrate the services. We have a very good comment by Dr. Alim Siddiqui, the president of the Indian Psychiatric Society. Thank you, sir, for mentioning this. He said that we keep talking about training of doctors, but what about paramedics, nurses, as they are more in number and probably more in contact with patients? Yes, exactly. That's the point we were discussing in the last round with the panelists, that training our grassroots level health workers is probably extremely important. And, we have seen this in our community work. Dementia detection, at least, does not really always require a medical expertise. So if you put a person through a proper training module, you may increase the rates of detection of cases. And that has come out in multiple community-based projects, including the Alzheimer, the recent ongoing, the first wave is completed of the Lassie study and previously of the 1066 dementia project as well. Dr. Nidhesh, coming to you again. So this is again regards to one of the comments that we have received. Caregiving forms a very important part of dementia care. In fact, the upcoming September, we have World Alzheimer's Month, where the theme is related to caregiving again. And it's very important for the caregivers to understand, not only in behavioral management, but also in staying involved with the person. So what would be your suggestions for the caregivers, particularly, I'll stick to the South Asian countries again, since there is such a huge load. And many people will not be really understanding the dynamics of this forgetting, since you mentioned that it is many times normalized. So what are the steps that you take in your clinic or in your training to, for the caregivers and for their mental well-being?
Okay, now just before answering this question, let me just compliment what Professor Grover has said. Like, in our country, I'm just focusing in my country, we are 209 psychiatrists. That comes around 0.7 in 100,000 population. We are now more than 29 million population. And we have only 25 around neurologists and 5 geriatricians. Okay, and we have 35 around clinical psychologists. So this is what the key lies. If we do not train our medical graduates, paramedics, nursing staffs, then the burden lies in the society. Now, again, to the caregivers, So what we have been doing in Nepal, earlier, even there are some supports from the government. We have organizations like Alzheimer and Related Dementia Society Nepal, or some geriatric societies Nepal, some societies are there. So they have started giving training to caretakers. There are about 80 care homes in Nepal. They are government registered, 80 care homes in Nepal, and 17 from private sectors. So what we have been doing is, we have been reaching to that place, and we started, talking with those people, like their burden, their issues, even their mental health while taking care, because many of the behavioral and psychological issues which they would not understand, they will start blaming the people living with the dementia. So we have started sensitizing them, and that should be done, because otherwise if that resources, if they are, they are overused, or if they are overwhelmed, or they get exhausted, then nobody would like to see. Not only that, what I believe is the caretaker training should be provided at the school level, because every one of us has grandparents in our home. We still live in joint family. So if we teach our students, if we teach our school going kids about these biological and psychological symptoms pertaining to people living with dementia, because I myself, I am a carer, not only as the psychiatrist, also I am a carer. Okay, so I feel what burden we may have at home, because I understand my mother has dementia. I understand all the psychological symptoms whichever I face every day. These are because of disease of the brain, but people may not know. So we have to focus right from the household level, from school level, and not to forget our policy makers, which is exclusively lacking in our policy makers. So because once we tend to focus these things, they are also caretaker for the society. May not be there, they are caretakers for the individual. So like the some of the financial burdens that the people have, like, because when we started focusing this, then our government has started providing 100,000 rupees Nepalese currency, which comes around 60,000 Indian currency, for people living with Alzheimer dementia, for their financial expenses, for their investigations, for their other expenses. So that has been done. And if they are 70 years and elder, everything is free for those people. So that financial burden, if we can reduce, and you can think that the caretaker's burden, some of the caretaker financial burden can be reduced. So not only one sector, we have to focus on multi-sectorial, like their human right issue, their economic right issue, their social right issue, and also issues of caretakers as well, and their mental health issues as well. So we have to start right from the household, again, I believe, not from the top down level, but from bottom to top level. Thank you.
Thank you, Dr. Nidhesh.
Dr. Devanjan, please call Dr. Sandip Grover. He has to leave first. Next. Okay.
Okay, sure, no problem. So thank you, Dr. Nidhesh, for highlighting this issue and maintaining, repeatedly stressing on the approach, which is very important, especially for caregivers. So before, we end, I would actually come back to Dr. Grover for the last quick comments. So since he's leaving, I will request Dr. Grover if he can, quickly kind of make a summarizing comment on dementia care in the South Asia and the way forward, particularly in training and services.
Yeah, thank you, Devanjan. I think what we have been discussing here, that we are trying to say that whatever resources we have, right from our grandchildren who are available at home, the nursing staff, the paramedical staff, MBBS students, and also training the postgraduate psychiatry students. So basically, we want to take a community mental health approach in addressing dementia, because when we take a community mental health approach, we involve everyone into the care. But I think besides focusing on this manpower, also we need to focus on the government policies. So we need to have certain policies where many people nowadays, what we are seeing, that old age people do not have caregivers available for them. So if they do not have financial resources, how are their needs going to be met? So there have to be certain policy decision, advocacy. That is where we'll be able to provide a holistic care and have whatever manpower resources we develop that can be utilized for old age people. So we need to understand, in nowadays we are having nuclear families, people are moving out of the house, old age parents are left alone. That's the real scenario which is emerging, and after 10-20 years that will be the norm. So till if we don't start acting right now, do not develop policies for this, do not make an advocacy for this, do not make the governments to commit for financial support to these people, we are in trouble in due course of time. Japan is already encountering this. We should learn from there and start working on it. Thank you, everyone. And thank you, Dr. Gautam Saha, for inviting me here for this panel discussion. I'm very sorry that I have to leave for another event. Thank you. Thank you.
Thank you, Dr. Dogar. Thank you for being with us today, and in spite of staying so busy. Yes, Dr. Nidhesh, I'll just come back to you in a while. So we had Dr. Grover with us. He's a professor of PGI Chandigarh in Psychiatry and the present editor, Journal of Geriatric Mental Health and the Journal of SAARC Psychiatric Federation. I would come to Dr. Wazizul. We are almost winding up our discussion. The ARTC report of India, the Dementia India report, is freely available. A Dementia India report of 2020, which was published by the ARTC Cochin chapter. So it highlighted the importance of setting up dementia clinics, at least as much as possible, if not in every district, but at least in state and in tertiary care services. So how important do you think is setting up memory clinics dedicated for dementia assessment and care And who do you think can run such clinics in South Asian setups? Dr. Wazizul.
Yes. It's to me, Dr.
Yes, yes.
Yeah, thank you. Thank you very much. Very, very wonderful question. Actually, I just want to go back to Dr. Nidhesh, who told about the family that I should say, the charity begins at home. If we don't respect our father, our parents, our kids will never learn this. So if we do this and our kids observe this, so there is a chance to have some support from them when we will grow older, otherwise it will be nothing or zero. So actually another important thing, that this career, I mean, it has been already discussed, the career opportunity for the students. It is our duty to convey the students, those who are making their career plan, that choosing psychiatry is a very wonderful career because, people of 65 years old and older are the fastest growing segment of population globally. Not only that, these people are not only developing simply the dementia or simply the forgetfulness. So dementia is not only the forgetfulness, it is a many things for the individual, for the family, for the community, and for the country. So if we can convey this message to the students, they may be attracted, and it is very important to increase the number of mental health workers if we could properly manage them to understand the utility or the importance or magnitude of the problem. So what is actually its main question, Dr. Debanjan?
Yeah, I just mentioned, the importance of memory clinics.
Memory, very good. Actually, memory clinic or geriatric clinic is very important because just to see the people, those who are older, those who are not capable of doing myself, just give them some special support. They should be considered as special people. Actually, we have become able to run geriatric clinic as well as geriatric outpatient department in our National Institute of Mental Health, and inpatient is already running, but by this time we have become able to running the OPD, even special OPD for the geriatric people or the elderly people. So it's a very tremendous job, and people with old age people are very happy to come over here because they know this part of the hospital is especially for them. So if we can set up this type of clinic even in the tertiary hospitals, this will be many things to support it. So really, I think every country, at least our Southeast Asian countries, this type of clinic for those people, so that they can understand that they are specially treated, they are special people, and they are being honored or dignified, and they have some dignity in the society. That's a really very good question. Thank you very much.
Thank you, Dr. Wazizul. You mentioned about dedicated care, which is extremely important. We also have a comment from Dr. Sharmishta, who mentioned the continuous need for counseling of caregivers, and the sensitization for community needs to start much earlier in college and school students. And yes, thank you for this comment. It is extremely important because we are all going to age, and successful aging is something that we all need to collectively work on. Before we end the panel, I would like to just take one quick ending comment from Dr. Nidhesh.
Thank you so much. I think I would like to highlight something about this caretaker and memory clinic. We have informal caretakers. Majority of the caretakers in developing countries are informal. Now we have to make them formal. Anything can be done, financial incentive, some job incentive, we don't know. Every countries may have their own mechanism, but that has to be done. Otherwise, this stress related to caretaking would be enormous. Number one. Number two, memory clinic. I believe memory clinics should be started from the primary healthcare center, and we should have memory nurse. We can teach them like common simple tools, like even simple mini cog or something, rudas or something, like some screening tools can be taught to them So once they screen out, the candidates scores more than the cutoff or less than the cutoff or something else, whatever we implement, that has to be referred. Once we only focus on, like, see, we have our, in where I'm working in my medical school, we have well-established memory clinic. I am doing that. But we also focus on establishing memory clinic in the grassroots level primary care center where our nursing staffs can screen. Even we can give some, 88 questionnaire to our the caretakers. They can screen out from their home. That can be taught at a school level. So basic screening can be done at the grassroots level, at their doorstep. Then further vertical integration can be done at the higher level. Then that can be the ultimate, because the maximum care, sky is the limit. But where is the minimum? Minimum should be there in the primary healthcare center. So memory nurse should be there in every primary healthcare centers. That's what I believe.
Thank you, Dr. Nidhesh. Thank you so much. We had Dr. Wazizul,
Dr.
Dr. Nidhesh, and Dr. Dogar.
Devanjan,
Yes.
I'm requesting, before concluding, before handing over to the chairperson, there are lots of senior psychiatrists over here. I have seen Dr. John, Dr. Abir, Dr. Hena Boras, Dr. Bhavesh, and Dr. Rubina from Bangladesh, Dr. Rachna from Nepal, Dr. Sedin is there. And if anybody wants to comment anything, you just ask.
Yes, please. Thank you. Thank you, Dr. Gautam. We'll take a few quick comments before we wind up. So anybody, if you want to post in the chat box or if you want to unmute yourselves, please go ahead.
Devanjan, Gautam, I'm going to have to leave too. I'm sorry, I'm in the middle of another meeting actually.
No problem, ma'am.
While
Please, ma'am, you
traveling,
can just
and
put on the winding up comments then, please.
It's been
Take
a
her
wonderful
concluding remark
panel,
as a
and I
chairperson.
really I thank all the panelists for giving these very valuable tips. And what they've spoken of are things that we need to really deal with at such a basic level. It's not something very elaborate. They are very basic, and they're things which are implementable. So maybe we can come out with a white paper from SAARC. And Devanjan, with Dr. Gautam Saha's permission, you can maybe lead that. You've done such a wonderful job as a moderator, and perhaps we should really jot down these points and see that all governments could get this message loud and clear, that this is implementable and this is necessary for geriatric mental health and care in all our countries.
Thank you, ma'am. Gautam, I'll just take a minute to respond to that. It's been a wonderful to be a moderator of this session for personal learnings as well. And as usual, thank you, Gautam Da and SAARC and IAGMH and AFPA for this opportunity. I'll surely try to do justice to that, ma'am. And I think to summarize what we discussed today, one is an integrated model of care. Second is a bottom-up approach, training primary caregivers, nurses, grassroots workers, and doctors, incorporating the training module in MBBS and MD psychiatry course as well. Having a model in all the South Asian nations, a common model for training and service delivery. And it will be my personal addition in lieu to what Dr. Alka mentioned, that we need to communicate this with the policy makers with the help of media if we have to make a meaningful change, because I guess nothing happens without promotion and advertisement. So it's a dialogue that becomes very important. Thank you once again for having me here, and I'd like to invite Dr. Nabaraj Koirala for the concluding remarks, and then over to Dr. Sharmishta for winding up the program. Thank you so much.
Dr. Koirala, are you there?
I think he's not there.
Okay.
Over to you, Dr. Sharmishta.
Fantastic discussion, and I think we have learned a lot from this discussion, and several things have come up which Devanjan has beautifully summarized. So now we'll quickly go on to the vote of thanks. We do not have Dr. Abdul Majid, but we have somebody who is equally distinguished, Dr. Rajshri Rai Bandopadhyay, and I think most of us know her She is the EC member of WPA section on religion spirituality. She's the EC member office, SAARC Psychiatric Federation, has actually plenty of feathers on her cap. So over to Dr. Rajeshri Rai Bandopadhyay for the vote of thanks, please.
Thank you, Sharmishta-di, and a very good evening to all the distinguished delegates and the speakers. It's indeed my greatest honor to be delivering the vote of thanks. All of you are very familiar, so thank you for being with us. In order, of course, the very first vote of thanks from the bottom of our heart goes to the organizing committee of this very special webinar, because old age and old age psychiatry is something that is going to affect each and every one of us. Either personally we might be affected with the diseases, disorders, and illnesses of old age, or we may be carers to friends and families. So it is really a very important dialogue that we've had a discussion, and it's one that has great way to go in terms of whether it's a white paper. So thank you to the organizers, led by the presidents of the three organizations, Dr. Gautam Saha, wearing his double hat of being the president of the SAARC Psychiatric Federation and the IAGMH, and Dr. Prasad Rao, for the president of AFPA. SAARC and AFPA have been doing a lot of work, and thank you, Dr. Saha, for leading the SAARC Psychiatric Federation exclusively in your momentous way. We've made wonderful videos on child adolescent psychiatries. We've had webinars on spirituality. We've had webinars on so many important topics. And of course, today was probably one of the most important ones. Of course, this webinar exclusively probably was the brainchild of Dr. Debanjan. And I know he comes up with some great ideas. So thank you, Debanjan, for giving us the opportunity to learn and to share our wisdom and thoughts. A heartfelt thanks to our chief guest, Dr. Afzal Javed, the president of the World Psychiatric Association, and to our very esteemed speaker, Dr. Carlos Lima, who is also the chair of the section of old age psychiatry of WPA. Our thanks to Dr. Imtiaz Dogar, the secretary of SPF, and all the panelists who joined us today, Dr. Sandip Grover, Dr. Sapkota from Nepal, Professor Dr. Wazizul Alam Chowdhury, sir, treasurer at SAARC, and of course, the chairpersons, Dr. Alka Subramaniam and Dr. Nobaraj Koirala. As you would realize, this webinar, all the pieces, the beautiful beads were all threaded together, and the master person orchestrating this was none other than Dr. Sharmishta Chakraborty, someone who's very near and dear, and as Dr. Saha said, she's one of the most distinguished psychiatrists of India and South Asian region. So thank you, Sharmishta-di. And behind the scenes, a grateful thanks to Dr. Shiraj, Mr. Shiraj De, from the Office of the SAARC Psychiatric Federation, for a seamless webinar and for recording and sharing this today. So thank you, delegates who've joined across the world and have made this occasion very important, because without yourselves, a dialogue is never established. Thank you, and over to you, Sharmishta.
Thank you so much, Dr. Rajeshri. It's like excellent ending to the program, and thank you all, the participants as well as the speakers and the panelists, for this whole experience. Thank you to Debanjan. Looking forward to more. Good night to all of you.
Yes,
thank you.
Thank you, Debanjan, again on behalf of me. You are great. Really, we are really lucky to have a younger brother like him, because he is doing a lot in this fraternity. And my respect to all the senior colleagues who attended this program. And we are really missed today the secretary of our IAGMH, Dr. Nilanjana Paul. He is very sincere as a secretary, but as right now he's traveling, she is not here. But thank you, all of you. Thank you, Sharmishta, for definitely anchoring all the program, full the program as a fantastically, Rajashri for fantastic vote of thanks, and all the colleagues from the abroad. I am not telling abroad because I always consider all Nepal, Bangladesh, Sri Lanka, all the countries. Bhutan is my country, so I cannot say abroad. All my friends, my brothers, I'm really grateful to you, all of you. Thank you.
Thank you, everybody.
Thank you very much. Thank you.
Good night. Good night, everybody.
Good night.